A couple other quick announcements I wanted to share. On Tuesday, September 7th, we will have our virtual youth group from 5 to 6 p.m. That is for kids and their parents. And then on Monday, September 20th, we have our virtual monthly meetup from 6:30 to 7:30. We're going to be talking about dental considerations and myasthenia gravis. So Dr. Graham Nas will be presenting on that. So we'd love to have you join us for that session. So with no further ado, I'm going to introduce Dr. Mamatha Pasnoor. Dr. Pasnoor is a professor of neurology and one of the wonderful neurologists that we work with at the University of Kansas. She is a wealth of knowledge on all things myasthenia gravis, and she's going to update us tonight on COVID antibodies. Dr. Pasnoor, do you prefer people put questions in the chat for the end, or do you want to answer them as you go?
I'm fine with either. Actually, I mean, they can go ahead and put in the chat, and I can answer towards the end if it's possible. Like, you know, in that way, we can just go through the slides, and then, you know, if we still have these in our mind, then we can, you know, go through each of those questions. So keep the questions coming in the chat, and I'll do my best to answer at the end of our talk, like all of the questions.
Perfect. Also, at the end of our group, you are going to get a survey. It is anonymous, and if you don't mind answering the questions, that would be great. So, Dr. Pasnoor, take it away.
All right. Well, thank you, Allison, for that introduction. And I think, you know, again, COVID is something which we all know is something new to us, and we learn a lot along the way. You know, this is as of evidence of, you know, that recent evidence that we have. You know, again, things can change and things can be different in a few months down the line, as you might realize by now. Like, there's a lot of things that have changed over the years, and over the last 1 year, I would say, not over the years, but in the last 1 year, you know, we didn't know anything about antibodies before now, and then we are learning more and more every day about the antibodies. So this is what our focus will be. And as I think all of you were already on previous sessions where some of my colleagues and I have talked about vaccinations and, you know, who should get it, who shouldn't get it, or do everyone need to get it? And I think by now, the importance of vaccination has been well established, and all of you are aware of that. And so now going on to the antibodies and vaccination and immunosuppression, I think these are the things that, you know, I see in the chat, and I also see that being a major topic for many people right now is, do I get a booster? When do I take it? Well, how do I take it? And what medications do I need to stop before I take it? So this is all kind of questions that, you know, hopefully I can answer some of them during this talk, and some of them, you know, we'll go through over the end of this talk. So going on, let me make sure my slides are advancing. Okay, these are my disclosures. Again, I won't be talking using any of that in my talk, but I do. I'm on the advisory and consultant for some of the companies that do MG medications, because that's my area of research and that's my area of interest. And so first, going on to what is an antibody? Again, many of us know what is an antigen. First, we need to know that anything that is foreign to the body is considered like an antigen. So sometimes the body defenses recognize our own body parts as an antigen, and that's how we develop the autoimmune disease like MG, where we have antibodies against our own receptors in the neuromuscular junction. And so something like that. In this case, the antigen, as we all recognize, is a virus that's coming into our body. And so the body, what it does is to fight that, it creates its own defense mechanism. And this is what we call as antibody. So the defense against this is the antibody. And there are different kinds of antibodies that are developed, and we'll be talking about these, and especially in COVID. And these are mainly the white blood cells, that form the antibodies, and they can be the antibodies can form from prior infection, or they can be formed due to a vaccination. So as we all recognize, there are different forms of antibodies that we encounter, and you hear a lot these days about these antibodies. And so going on to first is understanding what happens when you have an infection. So first is, if you had a coronavirus infection, the SARS or the virus which is the SARS-CoV-2, it initiates a humoral immune response. That is, you develop an antibodies which are specific to certain virus parts. So the virus has like a nuclear material in the center, and then it has a capsid, like a protective layer around it, and then it has the spike proteins on it. So when the antibodies can develop against any of these different parts, and those antibodies can be either the nucleocapsid antibodies, that's the N antibodies, or the spike protein antibodies, or you can have the receptor binding domains, and I'll show you a picture of that in the next slide. However, these are different antibodies that you can recognize or people develop when they have an infection, so they can develop any of these antibodies. And what do the tests do? The tests are basically trying to identify these various antibodies in your serum, and these can develop as soon as a few days to weeks, is what we have noticed from all the tests that have, all the research that has been done. So we understand this, as you know, like the SARS-CoV, when it started off like early last year to now, we have a lot of studies that looked at different antibodies when they start developing after an infection. So we learned a lot about like after post-infection, when the antibodies start off. And we have seen it pretty early on it doesn't happen, like you don't see antibodies the very first day of the infection, but you see it within a few days after the infection, and continue to last for a few weeks. Again, how long do they last? We don't have a clear idea of that. Does it last 6 months? Does it last more? Does it last less? We don't know that answer. And that's why, one of the reasons why we say, even after an acute infection, we want people to get vaccination as soon as possible, is because we don't know how long the antibodies last in your system. And do they provide immunity or not? We don't have that answer. So there's some evidence that these antibodies that develop after an infection may give you some degree of immunity, but that may last up to 6 months in some people, but it's not a consistent thing. Not everyone has it up to 6 months. So we don't know exactly how long they last. And we learn more and more, like I said, emerging, again, with the viral variants, like developing, as you remember, like, the first variant, now we have the Delta variant, and we may see something else in a few more months. So it might be different variants, and we don't know whether the antibodies that develop with the first infection, would they cover the Delta variant or not? We don't have that idea. We don't have that knowledge yet. So there is all these unknowns that we see. And so just wanted to show you a brief picture of this. Like, this is the SARS-CoV virus, and you see the antibodies developing against the various parts. It could be either the spike protein. You see the spike protein, if that is considered as an antigen, there's antibody produced against that. There's the receptor binding antibody that's developed against the receptor binding, and then there is you get the nuclear capsid antibody that's against the nuclear material inside. So these are the various antibodies that can develop after an infection with COVID, with the COVID virus infections. COVID-19, you can get antibodies through all these. So you can test all these antibodies, and we'll talk about like what is different with vaccination, what is different with infection. So, it's, although these, like I mentioned before, like it can be days or weeks that you start seeing these antibodies after infection, and we don't know how long they stay in the blood. And you have to remember, this is not an acute test for an infection. So if you're having symptoms right now, you may not have the antibodies right away. They take a few days to develop. So you want to, you still want to do RT-PCR or the rapid test for COVID virus infection, for an acute infection. So this is not a test for acute infection. You can look for prior infection with the antibodies, but it's not a test for acute. So, but if you're trying to look for, did this, say you're coming into the clinic and tell me that, I had some symptoms a few days ago, or a few weeks ago, and I'm wondering if I have COVID virus at that time. Can we test for that? We can do the antibodies, but however, not having them does not tell us that you had an infection or not, because your antibodies may have lasted only a few days or a few weeks, and may not have lasted that long. So it doesn't tell me whether you really had an infection or not. If you have antibodies and you didn't have vaccination, maybe yes, but otherwise it'll be hard to detect, to say whether you had a prior infection or not. And we'll be talking about some of that. So serology, antibody testing, clinicians, we usually call that as a serological testing, and commercially these are called antibody tests. So like you all know that it is called an antibody test. And what do we use this for? The US, the government has been using as for surveillance, like trying to see how many patients have been infected with SARS-CoV. Some of the patients, like I said, may have had some symptoms. Some people may not have had any symptoms. But if you do the antibodies, and if they have antibodies to the virus, then that there has been some infection. So that helps us to determine like how many people were had the infection. And so it is used as a surveillance method, and also for research purposes to see what percentage of US population previously were infected with this virus. And it helps us to understand and do more research on the pandemic and look at the public health. So that's what they have been using this antibody for. And based on what we know from similar viruses, some reinfections are expected. So it may not, these antibodies may not give us complete protection. You have to remember, even in flu, all of us get vaccinations, but why do we still get flu every year? Because there are mutants, there are other mutations, and there are different, even though you have the antibodies to one, there might be a different mutation this year that you still see, but you have to remember, overall your immunity is better than when the first time, if you didn't get the vaccination at all. So reinfections can occur, but the reinfections may not be as severe as the first one. And confirmed and suspected case of reinfection virus caused COVID-19 have been reported in some cases. And we do have few cases. And I have to say, even in KU, like some people do had reinfection, but the rate is very low. People who had COVID, reinfection rates are very minimal, and very few, I would say. So what are the commercial tests that are available to provide individuals this? CDC is evaluating these antibody tests. They check for SARS-CoV antibodies in individuals. There's different kinds of tests that have been developed. ELISA is one technique that has been developed and uses purified SARS-CoV protein. It's not a live virus, but this is something that they use, and also looking at minimizing cross-reactivity to antibodies, what we call as neutralization. But most of these tests have a high sensitivity and specificity at detecting the antibodies. And these can be used to identify, like I mentioned, previous SARS-CoV-2 infection in these patients. So up till now, I was talking about like what happens when the people have like a prior infection. We did not come to the vaccination yet, and we'll talk about the vaccination and how do we differentiate these two antibodies. So what does a positive SARS-CoV antibody test mean? That is either a recent or previous infection, and but sometimes these can be false positive. Like, when do we see false positive? So someone who has a positive test result but never had any symptoms, could be one of them, could be that they had infection and they didn't know it. But the other thing is, sometimes these have cross-reactivity to other kinds of viruses too. So these antibodies may have some cross-reactivity to other, like common cold or some other infections. So although these tests are good to identify, sometimes they can be false positives too. And positive test does not always necessarily mean that you're immune to the SARS-CoV. And if you don't know whether having antibodies to SARS-CoV protect, whether they protect you from getting an infection or not. Like I said, people can sometimes get reinfected, but the incidence is lower. So what does a negative SARS-CoV antibody test means? Antibodies to the viruses are not detected. It could mean that either you were not infected at all with the COVID-19, or if you had you had an infection, but right now you don't, you did not develop any antibodies, or if you developed antibodies, maybe they became undetectable now, so they when decreased, or if it is unknown if all infected individuals will develop these antibodies or not, again, sometimes we don't know that answer. Again, we learned a lot along the way. So these are some of the reasons why you may have a negative test for SARS-CoV. Again, this is still continuing on prior infection. We are not yet at the vaccination, but these are all looking at prior infection. So false negative, when do you get false negative? A test does not detect the antibodies, even though you may have had specific antibodies to SARS-CoV-2, and though you may have and tested soon, that can happen if you were tested soon after being infected. Like I said, it takes a few days for the antibodies to develop. So if you tested too soon, you may not see it. So you have a false negative. Although you have the disease, you don't have the antibodies developed yet. Or unknown if the antibody levels decline over time, like, do they decline in 1 week? Do they decline in 10 days? Do they decline in 6 months? Again, it varies with the individual person too. We have seen in some people, even up to 6 months, we did see the antibodies. So it's, again, it's hard to say who develops, who will have those for a longer period or not. So these are some of the things that you have to keep in mind. So many studies have been done with antibodies, like looking at a British nursing home, a fishing vessel, a summer camp outbreaks, and they documented that reinfection is less likely to occur in patients who have antibodies. And these were, and the sensitivity anywhere from 82 to 96% of the patients, like if they had the prior infection, the reinfection is less likely to occur, and if they have the antibodies to the SARS-CoV. And so maybe this is somewhat telling us maybe they are immune. However, this does not really tell us for sure that they have immunity. Has yet to be, that has something to be still determined. Like if you have a prior infection, does that create an immunity for reinfection? We don't know that answer, although some of these studies are pointing towards that they may be, but we don't know for sure. Again, that's something we have to learn along the way, just like everything we are learning in with the COVID infection. So now going on to antibodies to vaccination. So COVID-19 vaccines expose our body to the antigen. So you're giving a virus part to the body, and you're teaching your body to produce antibodies to fight the infection. And these vaccines induce antibodies to specific viral targets, like, so they may be like, the spike protein, or, a part of that virus is what we are testing. So, unlike the people who have the virus, prior virus infection, they may not have all the antibodies that we were testing for. So these will be specific to what vaccination you're giving, or what part of the body what part of the antigen you're giving to the body, and teaching them to produce the antibodies against that. So antibody testing, however, antibody testing may be positive or negative based on the specific test you're using. So if you're testing for nuclear capsid antibody, that may not be present in people who have vaccination. So you have to be careful, because people ask me, like, should I get the antibody testing? Yeah, you can get that, but again, you have to be careful. What are they testing for? Are they testing the levels? Are they testing whether to say this is positive or negative, or is it a particular part of the antigen that they're testing? So we need to know what are they testing there. We'll come to the next slides and see how many. There are a lot of tests available right now for antibody testing. Everyone, a lot of pharmacies are doing it, but there are different kinds of tests that have been approved. And so let's talk about that. Antibody testing is not currently recommended to determine whether you're immune to COVID or not. It doesn't tell us, like, should I get immune vaccination or not? It doesn't tell us that. It just is something that we are testing to see what your levels are, but it doesn't really give us a good information whether you need more vaccination or not. Or, that shouldn't be the deciding factor yet, at least from the present knowledge. And we'll talk some more about this. So antibody testing, again, it's used for, these methods have public health and clinical utility, and we use it for monitoring and responding to COVID-19 pandemic. So it's basically more like a surveillance. We're trying to see how, how many people have, what levels of antibodies people are developing with this, and, how do we need to respond to low antibodies? We don't have a definite answer to that yet, but that's something which we are looking at. And it's not useful to establish acute infections, just like the prior antibodies I was talking with, the prior infection. This does not tell us whether you have acute infection or not. For that, you still need to do the COVID test, the RT-PCR test. Many serological tests available, like I mentioned, but some of them have been approved by emergency use authorization and for public health and clinical purposes. So some of them just tell you whether you have, a positive or negative. They don't tell us what your titer is. That's also important. And these semi-quantitative results have been issued by emergency use authorization with FDA, and those are some of the tests that we use to identify and also help us to determine whether being on a certain immunosuppressive medication, does that suppress your immunity that you don't develop the antibodies? That's something we are looking at. Again, we don't have a good understanding of it, but that's something which we'd like to explore more on. And again, antibody testing is not recommended for to assess the immunity of COVID-19 following COVID-19 infection or vaccination, or to assess the need for vaccination as of today. But that can change in future. But this is not, we don't use it to say whether you need a vaccination or not. I know we are obtaining it, but it's mainly for our understanding of whether you develop antibodies or not, and we don't know yet, is this just the antibodies that help your immunity, or is it like a memory? Like when you give the vaccination, do these cells develop a memory in them that when the antigen comes back into your body, is it going to create new antibodies when it sees the antigen? So that could be a memory, and we don't know. So looking at the antibodies does not give us all the information, but we are using it more as a surveillance and see, is there a difference between one medication versus another? That's why we are collecting that, but it's not, shouldn't be used to whether you need a vaccination or not. So antibodies, infection versus, so this is also an important slide. Like I mentioned, again, we want to know, is it due to prior infection, or these antibodies are due to vaccination? These are some things that we have to remember. So it is unknown whether the natural infection confers the same degree of immunity compared to the vaccination or not, because when you have the infection, you have antibodies in your blood that develop. Is that the same way as when you get a vaccination? Again, natural SARS-CoV infection results in antibody development against all these proteins. The like I said, the nuclear capsid antibody, then the spike protein antibody, and the receptor binding antibody. So it develops antibodies against all of these, whereas vaccinated persons may test positive for only some of them, like the S, that's the spike protein subunit, and the receptor binding antibody, but may not have other proteins. So if you test all of them, and if you don't have N antibodies and you have SN RBD antibodies, then it tells you that it's due to the vaccination and not due to the prior infection. So there are ways to decide whether this is due to prior infection or this is due to vaccination. So there are tests that are being developed to identify these various antibodies. So none are currently authorized tests that have been specifically authorized to assess individuals who had received a vaccination. However, these are all in the development, and something we are looking at. And vaccination may also cause false positive results for tests that utilize S anti, but not for tests that use the N antigen. So for N antigen, so it doesn't cause false positive for the N antigen, but it does cause some false positive with S antigen subunits. Again, depends on what antibody you're testing for. You may have some false positive or false results. So again, it is also not known whether to what extent the extent viral evolution, that is the new variants, would impact the immunity from reinfection. So we don't know, like having these antibodies would that help us be immune against reinfection for the new variants? Again, the variants keep changing. I mean, you have the Delta variant now, we may have something else in future. Is it going to help us? And again, that's what is being studied by these these companies that produce the vaccination. Is they're trying to see, does this help with other variants? And we think, like, again, this is my opinion, and some of the physicians' opinion may not be everyone's opinion, but just like flu vaccination, we may have variants, but the severity will be less with the having these vaccinations compared to like not having vaccination at all, like not having vaccinated. So you may still develop some disease, and we may have reinfection, but however, this may not be as severe as you had seen with the initial phase of the COVID pandemic, and that's what we are seeing in the hospital presently. I mean, patients who were vaccinated are less severely affected than patients who are not vaccinated in the hospital, although they can get reinfection even with vaccination, but it's much, and it's a less percentage of patients, definitely less percentage of patients, and people who are more immunocompromised. And types of antibody testing, like I don't want to go through each of them, but like I said, there are different tests that you can do to identify these antibodies, some of them binding antibody detection, and laboratory tests like ELISA and chemiluminescent immunoassays. Again, we don't need to go through the details of this, but there are also like neutralizing antibody detection tests, that is in vitro. You're putting the virus, you're trying to give these antibodies and see if they inhibit the viral growth in cell cultures. So these are some of the ways they test whether these antibodies, test the antibodies. So there are various techniques that you can use to, so you can see how the companies and different tests are developed using all these techniques. They are trying to, so there is various techniques to identify these antibodies. So that's why when I say, like, you need to get it here, you need to get it there, that's because there are different techniques they're using. And as you can see, the IgG antibody, it's usually present for a longer time, and you might be able to detect that more. IgM is more for acute, phase, and IgM can last longer. So based on what they're trying to look at with these tests, you may or may not be able to detect the antibodies, or how long you would be able to detect the antibodies. So these are some of the tests that they do. So acute versus prior infection, like I said, natural acute infection is determined using a antigen test, and resolving previous infection best determined with the serologic testing, that's the antibody presence. And these are, so I just wanted to highlight, this is from the CDC and the FDA websites that have pulled up some of the information. You can see that there are 65 different tests for SARS-CoV that have been developed up till now and have been issued the emergency use assessment for these by the FDA. So you can see how many tests are available there out in the world, like for these for looking at the antibodies, and some of them are qualitative and some of them are semi-quantitative tests. Actually, the one which we do at KU is the semi-quantitative test, which tests the antibody levels also. It tells you exactly, like, what your antibody levels are. It tells you whether it's less than 0.4 or more than, we only test between 0.4 and 250. And so we're looking at units between that. And if they are more than 250, usually, what KU has done is they looked at some 47 volunteers, just normal people who do not have any problems, and looked at what their antibody levels are. And after vaccination, this is after vaccination, and they've seen the antibody levels were greater than 250 units. And so based on that, and people who were transplant, and I'll show you some of those slides later on, but with transplant may have a lower level. And so based on that, we are doing the semi-quantitative testing. And so there are different tests that are available out. Some of them do not give you like whether they do not give you a levels. They just tell you whether this is positive or negative. They really don't tell you what level is it positive. Is it like lower level positive or higher level positive, or is that level enough to keep you immune or not? We don't have that answers. So, but serologic tests with high sensitivity and specificity are preferred, and so we look at that. And IgG levels, as I said, decrease more slowly over the weeks, and so that's why that it might be better to do IgG assays, look at IgG, whereas detection of IgM may suggest more relatively recent infection. So the FDA has issued EUA for competitive neutralization testing also. So these are some of the tests that we use. But like I said, the semi-quantitative tests, although have not been specifically used in clinical and public health, but we have been using some of them at KU, and some other places are doing that. As far as the first vaccines distributed in the United States, just going on vaccination, they induce the S protein. That's what I was talking about, the spike protein, and antibodies against the spike protein is what you're trying to identify. Presence of antibodies to spike protein indicates that either previous natural infection or vaccination. However, if you don't have N protein, then this is due to vaccination and not due to prior infection. And sometimes if the N protein has waned off, they have decreased over the period of few months, you still can't say if it is due to infection or due to vaccination. However, I think that's one of the ways we try to figure out if this is vaccination or is due to prior infection. Since vaccines induced antibodies to specific viral proteins targets, post vaccination serology test results may be negative in people without prior history of natural infection, and tests used to detect these antibodies. So you have to be careful. What tests are you using and what tests? So if this is testing only the N protein, you may not see that in vaccinated post-vaccination tests. So you have to be careful about what you're looking at. You have to look at, so for vaccination, you have to look at specifically vaccine-induced protein antibodies and not, the prior infection antibodies. So they're two different, they're different tests that you can see. A negative serological test does not prelude previous infection. So a proportion of persons who are infected, like I said, they may have a gradual decrease of their antibodies, which you may not be able to see. So just going on a little more on the antibodies, like I said, particularly the IgG antibodies may persist for many years, and serological tests may be interpreted in different ways. If a person is vaccinated, like I said, testing positive for antibody against NS or RBD indicates prior natural infection. However, if you were vaccinated, this is if you're never vaccinated. If you're vaccinated and testing positive for antibody against the vaccine antigen target, may tell you, such as S protein, and negative for others would tell you this is vaccine induced and not infected person, not previously infected. And testing positive for any antibody other than vaccine induced antibodies such as N protein indicates some resolving prior SARS-CoV infection, and that could not have occurred before or after vaccination. So that's something which you have to remember. Like I said, N protein is more specific for the prior infection, whereas S protein is more for antibodies against S protein is more for vaccinated. So if you're unvaccinated, again, the important thing to remember is if you're unvaccinated, we still want you to follow all the precautions, and antibody testing is not recommended to assess the immunity. However, like if you had a positive antibody test, that tells us maybe you had infection previously. So that basically gives us some guidance that you had prior infection for unvaccinated people. But this may be positive only for a few months, and it may not be positive beyond that. It doesn't tell us whether you're immune or not to the infection, even if you have the antibodies. You have to remember that, you may be testing positive for antibody. That doesn't tell you like your reinfection would be less, or, is that, so you could still be reinfected, could be still, and you could still be spreading the virus if you get the virus. So you have to remember that, unvaccinated people having the antibodies does not always tell us that you're immune to it. And we still suggest getting the vaccination in those people. And so coming to additional dosing of vaccination, you all were excited, and just like we are, about this learning about the booster. When do you take the booster? These were a lot of questions from most of my patients. I think it was on everyone's mind. Do I get the booster? Should I take it or not? Or when should I take it? So this was as of 13th August 2021. The CDC has recommended that anyone who's immunocompromised gets an additional dose of vaccination. And when do you get that vaccination. Actually, they didn't really specify exactly like how, but they said anytime after 28 days from your last vaccination. That is, you had 2 doses of either Moderna or Pfizer vaccination. They're only talking about mRNA vaccination. This is not yet indicated for J&J vaccination. It's only for Moderna or Pfizer vaccination. And at least 28 days after the completion of the initial mRNA COVID-19 vaccine series, you give this, and you can take anywhere after that. So if you are immunocompromised, and what is immunocompromised? Who qualifies for immunocompromised? So I mean, they started off with like solid tumors, hematologic, like people who have cancers, are on chemotherapy, or if they are on treatment called CAR T therapy, or if they have immunodeficiency syndromes like DiGeorge syndrome. These are some of them are in kids, some of them are in adults, and people who have HIV infection, untreated HIV infection. And among, I mean, I think for us more important is what, I mean, because most of our patients in MG world are on prednisone, methotrexate, CellCept. These are all immune suppressive medications, and so what they said was like prednisone, if they are on greater than 20 milligrams per day, or if they are administered over 2 weeks, these are what we consider as being immunosuppressed. But I have been telling my patients, even if they're on low dose prednisone, just go ahead and get it, because there's some degree of immune compromise in that. And again, I mean, if you look at the last sentence, they said the healthcare provider can possibly, in consultation with other specialists, can determine whether a person is immunocompromised or not. And so presently, if you go to any pharmacy, and like if you say that you are immunocompromised, they cannot refuse getting you the vaccination. So if you feel like, and you can, I think it's always good to talk to your physician, who's seeing you, just discuss with them. And we have been, again, few weeks prior, like, maybe if you had asked me in July, I didn't have the answer whether to get the vaccination or not, the booster or not. But now we have clear guidance on this, and we have recommendations, I would say, recommendations from CDC about, all immunocompromised patients. And even KU has been doing it, but KU is randomly sending, messages or my chat messages, as well as text to patients who need to get that. It started off with the like transplant patients, but other patients are also being randomly assigned. But if you are immunocompromised, talk to your physician. If it's my patient, whenever I see someone, I've been telling them to just go ahead and get that vaccination booster right now, if you're immunocompromised. Again, just being on Mestinon is not an immunocompromised status. It's the other medications that you're looking at, any of these medications. So these are all the other medications. And then CDC recommendation. At this time, CDC does not recommend any additional doses for people who have received J&J vaccination, because we don't have enough data yet to say that they need to get a vaccination, the J&J series. And, some people may have the question, like, I got J&J, can I get mRNA booster? We don't have that answer yet. It's not enough data to support that yet. So if you get one vaccination, can I get the other? We don't have that enough information on that. Right now we say, like, if you have an mRNA Pfizer vaccination, take the same booster in the same series, so, but only mRNA we don't have for J&J yet. Again, those are studies going on for that too, and we might hear good news about like need a booster or not for that too, or maybe they'll come back with evidence saying that it lasts longer. We don't know yet that answer. FDA and CDAC are actively working on providing guidance on this issue. And so after thorough review of evidence and advisory committee on immune practices composed of medical public, they came up with this, that in addition to getting booster for people with immunocompromised, they also said, like, people, other, general public can also get it, like a booster 8 months from the second dose, and they're going to start that on September 20th, 2021. So, again, if you're immunocompromised, I would suggest just go ahead and get it as soon as possible, because once they open up for others, we might see a bigger rush on, and there might be less, availability of spots there for the vaccination. And we do have a lot of vaccination still, but there just might be a lot of people getting their boosters starting on September 20th. Again, they're going to, and how do they release that? Again, I think the plan is to follow the same way that they had the first dose, that, the first time, starting off with the frontline workers and then continuing with others, just like they had the phased vaccination protocol like in the beginning. So we're going to see that pretty soon for the rest of the population. But for immunocompromised, you just have to say that you're immunocompromised and you can get your vaccination. So that's the effective third doses. And talking about third doses, so CDC right now recommends getting this third dose, like I said, all immunocompromised regardless of prior source SARS-CoV infection. And the timing of when a person receives the additional dose may depend on this is for people who have prior infection. People with current infection, infection until the person has recovered from the acute illness and until criteria have met to discontinue the isolations, then you wait until that and then get your first and second doses of COVID-19 vaccine, just like you were doing before. And people who previously received passive antibody treatment, that is, who have got virus infection and you received the passive antibody treatment, how long do you wait? Typically we are saying 90 days for those people who received like the convalescent plasma monoclonal antibody therapy, usually about 90 days is what we are suggesting before receiving a vaccination dose. So that's something which have been, and the second dose is the same as the other recommendations we have. And antibody testing, right now, FDA and CDC do not recommend using serological or cellular immune testing to assess immune response. Like summarizing all this, although we test these antibodies, it doesn't really guide us on whether to give the vaccination or not. We don't look at the antibodies to say you need vaccination or not. If you're immunocompromised, just go ahead and get your vaccine, the booster. And to determine if someone needs an additional dose, again, that is also, we don't use it as something, but we are testing it just to get an understanding of whether people have low levels when they are on certain medications or not. So again, you use it as more as a surveillance, but not as a guidance for immunization. You can't use that as a guidance for immunization, but just we are using it as a surveillance right now. So utility of serologic test or cellular immune testing to vaccination has not been established yet, but again, that can change just like everything else in COVID. So people with immunocompromising conditions or people who have who take immunosuppressive therapies are at increased risk for severe COVID-19 illness, and that we have seen in multiple studies. What happens is, people are on immunosuppressive therapies, they have a lower, reduced immune response to the COVID vaccinations, and that's something we are trying to understand by doing all these studies, trying to get the antibodies and looking at that. Although we don't know what level is useful for immunity or not, that's why we don't suggest that as a point to look at when to get vaccination, but something to think of. We are trying to do that analysis, and higher rate of breakthrough infections has been seen than in general population in people with immunocompromised. That's why we say get a booster dose, and additional mRNA vaccine dose may enhance the antibody response. That's why we recommend that. Although the clinical benefit of an additional dose in immunocompromised has not been precisely known, but we think that there is a potential to increase the immune response, along with we know that they are pretty safe to take. And so I'm sure a lot of you already asked me. I mean, many of my patients in the clinic have asked me, and I said, go ahead and take it. And so, like I said, I mean, if the question was asked in July, I would say, let's wait and see. But, right now we have the, the recommendations from CDC. And so we go ahead and, tell all our immunocompromised patients to take that. And Sorry, I think went back there. So this is, just to show again some of the studies that have been done previously with immune suppression, with vaccinations. Can what do we see like with these with the medications? So there have been some meta-analysis, studies done previously with other vaccinations. I'm not just talking about COVID, but this was a meta-analysis looking at people who are immunosuppressed with different medications, and what their conclusion was that rituximab displayed a poor when you're on rituximab, you're suppressing all the B cells. So when they gave the influenza or pneumococcal vaccination, they saw that there's less antibody response to the vaccinations in these people, because it suppresses all the B cell activity of that. And patients on tumor necrosis factor, that was another, also showed, again, this is used in some conditions, and that has been shown to reduce response to the vaccine. So other immunosuppressive therapy, this is more recent paper from rheumatology literature looking at SLE and another rheumatologic condition, and they looked at anti-SARS-CoV, the receptor binding antibody titer level and different medications. You can see the medications here. This is overall, just being on any medication, any immunosuppressive medication, this was the antibody. But if they're on Cellcept or rituximab, you can see the antibody titers are lower. I mean, there are some people who had normal antibody titers, but there are a lot of people that have lower antibody titers in these. And if they're on glucocorticoid or steroid monotherapy, again, they did not have a significant reduction. And if they have some glucocorticoid, like they had some steroids along with others, they still had good, I mean, many of them had good, I mean, some of them had lower titers, but many of them also had normal titers. But people in rituximab and mycophenolate group, that's the Cellcept group, did have lower antibody levels. This is just looking at people who are vaccinated and had, this was rheumatology literature. Again, and based on some of the studies that they have done in rheumatology, again, you have to remember, like, rheumatology is another big area where they have immune suppressed. We don't have specifically in myasthenia gravis. That's something which we are still looking at in neuromuscular conditions, but this is most of our knowledge is from rheumatology, where people are immunocompromised due to being on different autoimmune conditions. There are different immunosuppressive medications. They use something similar to what we use, like the Cellcept, the methotrexate, the steroids. So this was based on all these studies. This was a recent paper published in March of 2021. They have looked at this was a summary, and they came up with some of the recommendations, and you can see here. And again, do they do these recommendations? Do we follow these recommendations? Again, not yet. Again, we can use that as a, we don't know the answer in MG patients. This is in rheumatology patients, but these are immunocompromised patients. As you can see, like methotrexate, they recommended, like in this, the recommendations were, or I wouldn't say recommendations, but the consideration. They wanted us to consider stopping methotrexate for 1 week each after the 2 mRNA vaccine doses for those well-controlled disease, no modification. So if you were getting, for example, rituximab, low, able to mitigate, like they said, like at least approximately 4 weeks prior to the next scheduled rituximab cycle. So give a dose, give the vaccination 4 weeks prior to the next cycle is what they are recommending, or delay rituximab 2 to 4 weeks after the final vaccine dose if disease activity allows. Again, you have to remember, these are considerations. These are not a specific recommendation. They want to, again, you can see in the bottom, they did say, again, you consider that the patient is stable. Like if you're on a stable disease, like say if your MG is stable and with the medications, or maybe you're on methotrexate, maybe you're on Imuran, or can we hold it for a few weeks before and after? Or based on these recommendations, they are saying, I mean, based on these considerations, they are saying some of these medications it's better to hold for few weeks before and few weeks after. Like for mRNA, they said 1 week after each of the 2 mRNA vaccines, hold this. For methotrexate, for the J&J, they said like hold methotrexate for 2 weeks after the single dose COVID vaccination. vaccination, if you have well-controlled disease, again, you have to remember, if you have well-controlled disease, if you are having symptoms and, you hold the methotrexate, you may have, or Cellcept or whatever, you hold this, you may end up having, severe MG symptoms, end up in the hospital. We don't want that to happen either. Even without holding it, we still recommend getting the vaccination, because not having the antibodies at all is worse. Not having immunity at all is worse than, at least having some effectiveness. Again, you may not have the full effectiveness if you're on the immunosuppressive medications, but it's still beneficial to have some effectiveness. So this was rituximab, this was, Zyclo. We don't have everything. We just have like a few of these which are used in, so mycophenolate, they asked hold for 1 week following each vaccination, for the immune response, So there are different, consideration that they have discussed here. Again, if you're on, if you look at Imuran, that's azathioprine or cyclophosphamide or belimumab or this, they said you don't need to do any modification to your therapy and level of test. So these are all, again, some of them are strong evidence, some of them are moderate evidence. So these are all that we know from the rheumatology literature. So we don't have much in our own, but this was our experience. Again, this is just I'm just showing some patients that I obtained antibodies. Again, we are continuing to obtain antibodies. Again, this is to see like what happens with the antibody levels with being on some of these medications. This is something I'm looking at, but again, I don't know if we have the answers for people in MG yet, but that's something we might come up with recommendations in future. Again, I know that some of it might be delayed, but I'm looking at, if you look at this, like someone who was on rituximab had no antibodies, but that test was a qualitative, like just negative or positive test, so we didn't have the titers on that. But if you look at Cellcept, again, the titers, one person had low titers, but another person who was on Cellcept had no titers at all. I mean, not low, but slightly, I mean, this is about normal, but still had lower than people who were on prednisone alone, or people who were on Imuran. Again, people who were on Imuran and prednisone, some of them had low titers, but some of them had high titers. So it's hard to say right now based on this small study, but we are looking at more larger. This is just my patients I've looked at in the last month, but I'm sure we'll, like in a few months down the line, I'll be able to give you a little more information on, this is the antibody levels that we are testing in our group of patients. You can see that antibodies there. And again, with different vaccinations. Again, we have J&J vaccination, we have Pfizer vaccination, we have Moderna, and some of them I don't know yet, but that's something which I'm capturing, more information. So I should be able to get you more information on that. So that's about the antibodies, everything about the antibodies that we know up till now. Again, I have to say that changes, and this pandemic has, we have learned a lot along the way, and it keeps changing. And I'm sure our knowledge will be more as we go along. And this is what we have up till now. And I'm ready to take any questions. I can look at the chat and start answering some of the questions. I see a lot of questions already came in. I think one of the questions that was emailed was about plasmapheresis and antibodies. Again, plasmapheresis or plasma exchange, as you all know, it filters out the blood of certain antibodies. And, again, we are doing it to remove the antibodies, the myasthenia gravis antibodies. And we don't know specifically if they remove this antibodies or not. That hasn't been studied. However, in prior studies looking at plasma exchange and meso-IM and some of the other antibodies in the past, they have looked at that during, and I mean, immediately after the plasma exchange, there was some decrease fall in the antibody levels, but they rebounded, and they did see increased levels few weeks after that. So again, I mean, I wouldn't say that would stop us from getting the vaccination. I would still get the vaccination, and hopefully, it would be nice to space it out a little bit, before giving it some time for the antibody response before you start filtering it out. So wait for a few, maybe 1 or 2 weeks before you get your plasma exchange after the vaccination. That's what I would suggest, although we don't have enough evidence at this point to even put that as a recommendation. We always discuss with your doctor also. on that. And then I see that has said, I am scheduled for a third Moderna vaccination this coming Friday, and I'm on CellCept. So again, I would definitely say discuss with the doctor you're seeing. But according to the rheumatology literature, they're suggesting like 1 week, waiting for 1 week after to restart again your medication. But if you have fluctuating myasthenia symptoms, it may not be good to stop. So always discuss with your physician to make sure that you have stable disease before we hold that. Again, this is just one literature. We don't know our own group of patients, and we don't know how myasthenics, how that affects in myasthenia. Is it 1 week? Is it 2 weeks? We don't know that answer. But I would still, I mean, even people who were on CellCept and got the previous vaccination, they had high antibody levels, but not as, I mean, again, just the small group that I've shown, they do have antibodies, may not be as high as some of the others, but they do have antibodies. So is that enough to help with the immunity, or is it something else? We don't know. It's still beneficial to take the vaccination, but I would suggest also discussing with your physician before you hold that for a week after the vaccination. Rituximab, I think this was a question by Dana. Rituximab wiped out my COVID-19 vaccine. How long after my last infusion should I wait to get the third Pfizer dose? And as you saw in this paper, like they have suggested, like if you look at that, assuming patient to be mitigated, they said like initiated, the scheduled vaccination, that vaccine series is initiated 4 weeks prior to the next scheduled rituximab cycle after vaccination. Delay rituximab 2 to 4 weeks after the final vaccine dose. So they're suggesting, so what we are looking for is like, we want the antibodies to form after so if you're getting every 6 months the infusion, I would do like in between your like 3 months after and 3 months before the next infusion might be the best time to get the vaccination, and like at least have 4 weeks before the next dose to develop these antibodies after the vaccination. So that's the recommendation those are the consideration in this paper. Again, that like I said, discuss with your physician also, but that would be something we know from this literature. I would suggest like in between those two, between the two infusions, if you're getting it every 6 months. And let's go on with see if there are any other questions. Can I also schedule my shot at St. Francis Hospital? Let's see, what did they say? Because of the travel, can I schedule my shot? Yeah, you can get the booster anywhere. You don't have to come to the place, where you got the previous. Right now, any pharmacy, like so a lot of my patients are getting it at CVS pharmacy. You can get it anywhere you want. So you don't have to have, just at KU. You can do it anywhere possible. And then I work at K-12. This was a question from Jennifer. And I work at K-12, school. Last year students had COVID, hardly had any symptoms. This year students are getting really sick quickly and a lot more sick. What is the thought to this? So that's a good question, actually, Jennifer. I think one of the things you have to remember is the Delta variant. The mutation, the variant we have seen in other countries, like in India. There has been this has created quite a lot of problems in India. The thing is, it's not just being more sick. I think it's also because it's faster transmissible, like compared to, I don't think the people are any more sicker than what was with the prior thing. You have to remember again, most of the kids are not vaccinated, under 12 are not vaccinated yet, and so they have a high risk of getting the COVID, and the transmission is higher than what we have seen with other variants. In India, like the people, if one person in the family got it, everyone gets. It's almost like transmits even before they know that the person is sick. Everyone else gets, has the COVID symptoms. And so it's basically the transmission is high. That's what we know from experience in other countries with this variant. So yeah, yes, I think that, I hope that answers your question, but I don't know about whether they are any more sicker. If you look at the hospital census and everything, I know in other countries it did have more impact. I mean, especially in India, like people, I mean, there were a lot of people who died and a lot of people who were sick in the hospitals, but that also because they did not get any vaccination at that time. Now after they're getting vaccinated, probably it's lesser that we are seeing. So I think again that could be just the variant, the mutation, the variant that we are having now, the Delta variant might be more transmissible. Does an antibody test have a standard range for those that have been vaccinated? So that is a good question, and this is something which this is Sandy has been asking that. Sandy, I know again, that's an important question. Is there a standard range? You're right. I mean, I mean, the range should be like for people who are vaccinated, at least at KU, like I mentioned, they have checked in volunteers like who were not on any immunosuppressive medication, and 46 out of the 47 had more than 250 units in them. So that was the titer that we had in people who were vaccinated and did not have any immunocompromised status. So I mean, but again, do we know, like, do we all need like about 250 to be immune or not? We don't know that answer. And so if you look at what I presented here in my slides, most of our patients are not at 250. There are few patients who are at 250, even being on some of the treatments like prednisone or other treatments, they are about 250. But majority of them are not, they are lower than that. And that's being on different medication, like someone who's on prednisone 20 milligrams, I've seen low. So this is just my small experience, but again, this is not any publication or anything. Again, it's not something we have published. It's just my experience from our own database, and so this is just what I collected. But again, I think something which we have to look at more before we say that that there is a specific level that above which people are more more immunocompetent or not. But I'm just looking at all the immunosuppressed patients, but a pathologist has looked at normal, like people who are not on any immunosuppressive therapies, and they have seen that. And so we don't, to your answer, no, we don't have a definite range. I mean, it should be above 0.4 and less, and about 250 would be great. About 250 would be great. But, again, at what level do we consider as abnormal? Normal, we said like anything below 0.4 is, low, and, we don't have, the titer is very low is what we say. But, again, between that, we don't know what level is a good level. And that's something which we are trying to understand still. And does an antibody test have, so that's Sandy, I think I answered that question. And the next question was, let me see here, Bud has asked the next question. My endocrinologist had me take SARS-CoV-2 antibody IgG spike semi-quantitative test, which came back with no antibodies, had a booster Moderna, took Solidus just before booster, same day. Okay, yeah, so again, that works on the complement system. Again, that we don't know if it really affects your antibody in any way or not at this point. So I would say, at this point, we don't know the answer, whether it affects or not, but I would think it, again, just like any other immunosuppressive therapies, again, taking a booster is definitely good. And you said like before booster, same day. It shouldn't, my thinking is it should not cause much of an effect, because we're not suppressing your B cells. It's a complement system. But again, that's something which we might be able to look at. again, we can do the antibodies and see later on and see what the antibodies, and we'll learn more as we go along when I look at more people with the, with the Solaris. So at this point, I don't know if I have a definite answer to that, but. And then going to will retransmit to everyone. Let's see, what was this one? I'm sorry. Will retransmit to everyone. Why is it taking so long to develop vaccine for those under 12? This is from Stephen Case. That's a good question. Why can't we give everyone, right? I mean, I would say I wish it was that easy to answer that question, but it's a good question. Why not give everyone under? But again, any trials have to go through a rigorous process, and I'm sure we'll hear that pretty soon. And you have to remember the trials. It's always difficult to enroll patients. Also, to do the trials is also very difficult. I mean, we have a lot of MG trials that we do at KU, and it's not always easy because not everyone is. You need a certain number of patients or people to get answers, and it's always difficult. People are, even with them being approved, you see only 40% got vaccinated, and if they haven't been approved and haven't been tried previously, it is even more difficult to enroll into the study. So it's hard to just give them without a study. So the studies are ongoing, and we might be able to answer that pretty soon. And we were expecting that in September, and but now I think it's kind of pushed a little bit, but we hopefully will get that in the near future for all under 12 also. And going on to Jennifer's another question, when is it determined to give someone monoclonal antibodies when they have COVID? That's a good question. Again, there are clear guidelines for monoclonal antibodies, and previously it was if you had mild to moderate disease, and there is a protocol that the infectious disease group has developed, and based on that. But now they are looking at even the more severe who have been admitted. These were mainly being given for people who were not admitted and came to the ER and had like moderate disease, but now they are looking at even giving them to this more severe cases also, the monoclonal antibodies. That is more for acute treatment. Again, that's something which probably more of an acute people who have the symptoms that's given to. And the next question, Brian Bosch, Grifols, the makers of Gamunex C, informed me that the IgG as of last August had COVID-19 antibodies, and I'm receiving them in my monthly infusions. Have you been informed of this, or know if any of the IgG manufacturers have COVID antibodies in the IgG as well? I have to say, I haven't heard of this. I know that the convalescent plasma was being used for as a treatment in the past, but right now there's no specific recommendation for that. So I'm not sure about this. I have to I think I have to look into that. I haven't heard of that. To your question, have you been informed? I didn't. So that's something which I need to discuss a little more with Grifols and see. I don't think I have that. I mean, I know that COVID antibodies, I mean, it's been used for people with, who had the infection. That was one of the treatments in the past, but now it hasn't been, again, we're not using the convalescent plasma anymore in patients, but that was something which I have to look. And in fact, I thought they were testing for patients, not, screening patients for infection and not using serum, but I have to find out about this. I have to get back on that one. And let me see. I think Catherine did say about immunocompromised chemo patients. That's this will assist. Yeah, definitely. I hope it helps you on that. And what about cases where they say that the vaccine caused autoimmune disease? How can that not hinder someone, say that is on prednisone controlled, that is on prednisone controlled MG. I did not understand the second part of this question, Christine McQuay here. The first part of the question, what about the cases where they say that the vaccine caused autoimmune disease? That is a good question. Again, to your question about can there be autoimmune disease? What is an autoimmune disease that you develop with post-COVID vaccine? I mean, with vaccination. So one of the things, again, I mean, being a neurologist, I have seen a few cases of GBS, which is Guillain-Barré syndrome, where people develop numbness, tingling, and progressive weakness. I mean, some weakness initially. It's an acute, I would say, like it's a subacute weakness, and this can happen, and it can happen with any vaccination. It is 1% chance of developing that. So think of it this way, like, I mean, it's 1% chance of developing, but the chances of getting the infection and, having serious consequences from the infection is high. So, looking at that, the vaccination risk is there with any vaccinations, like, whether you take flu vaccination or whether you take measles, mumps, anything that, we are taking, there is a small risk of side effects. So there is, it can cause, I mean, I wouldn't say it is an autoimmune disease, but it's, again, there is treatments for that. If it's caught early, like, there is treatments that we give. And I mean, my patients the patients I have seen who had that, GBS, again, some of them, I mean, maybe may have just minor symptoms that they've recovered completely. Some of them may have a little more symptoms, but it's not a huge number of people, but there is definitely a small risk, but that shouldn't hinder us from taking the vaccination. So, and that is, I think, the second part of your question. I wasn't very sure what was the question. That is on prednisone controlled MG. How can that not hinder someone say that is on prednisone controlled MG? So, well, I mean, I think you're trying to say if could this be MG and not another autoimmune disease? Is that what, I mean, well, if that's what it is, like you're right. I mean, sometimes they may overlap, but the thing is with the condition called GBS, there is more sensory symptoms, unlike MG, where there is no sensory. When I mean sensory symptoms, I'm talking about numbness, tingling. We didn't see that with MG. We don't see that with MG, whereas with GBS, they develop this pain, numbness, tingling, in addition to weakness. So it's slightly different from MG in those patients. So good questions. I think that's probably the last of questions. If I missed any questions, let me know. I think, Christine, you said that, I guess I'm wanting to know if there is a greater risk for someone who already has an autoimmune disease for getting GBS or another autoimmune disease. But so fortunately, I have to say, we haven't seen GBS in a patient with, in a MG population. So it doesn't have to be like, people who have one autoimmune disease have, develop another one with the vaccination. It doesn't have to be that way. So, and especially with our experience, I haven't seen any of our MG patients developing GBS yet, at least, I mean, from the small, I would say, at least we see a lot of MG patients in our clinic. So at least among my colleagues and me, we haven't seen anyone with the, in MG developing this, but we have seen just people who did not have any autoimmune disease had developed this, so it doesn't have to be just if you're or if you have an autoimmune condition, you develop this. It doesn't happen. It doesn't have to be that way. All right. I hope that answers your question, Christine. And Amelia said, similar to yearly flu vaccination that are developed for a particular strand, not every year they get the right strand. What strand? I think when this vaccine was developed, we did not have the Delta variant. How effective is this vaccine now that we are predominantly Delta variant? So that is a good question. Again, this is all a learning experience as we are having more people develop so right now, 90% of the patients who are sick sick have the Delta variant. And at KU, we have like close to 100 patients right now. And, again, they're not specifically, they did not tell us how many, but they did say a percentage. They said like about 90 to 95% of patients who develop, who are being hospitalized right now have the Delta variant. And so looking at that, still the number of patients who are vaccinated are very few that are being hospitalized. It's mostly unvaccinated. So that itself tells us that, that this vaccination may be helping the Delta variant also. And those studies are ongoing in the Pfizer and Moderna. They're looking at that, information also. But that's something which we'll learn along the way. But just looking at the experience at KU, we see that vaccinated people are definitely less sick and less number of patients that are getting affected. Like out of the 100 patients, it's only about 5 or 6 that are less than 10 are hospitalized, and out of which that most of them are just on the regular floor and not in ICU. Only about few patients are in the ICU. So, but none of them are right now on ventilators or needing like the severe protocol. So I would say based on that experience, I can say like probably less number of patients. But again, we need more studies. So we will probably hear more about how effective it is. But even in other countries, we are seeing that mRNA vaccines, or I mean, not specifically like Moderna or Pfizer, but just the mRNA vaccines have been helping the people who basically in India, there's been Delta variant has been the main cause for their COVID spread in the last phase, and with vaccination that's coming down. So we are seeing that. So you're right. I mean, with the strand changing every year, just like flu vaccination, will this cover all the mutations? We don't have that answer, but we are hoping that it would at least cover to some extent, that they may not be as sick as you would be when you're not vaccinated. Just like flu vaccination, the reason we take it, we still might get flu symptoms, but we may not be as sick as we would have been if we did not get the vaccination. So this is the next question, are they able to or trying to determine which variant is present upon testing, or are we just assuming it's the more transmissible Delta variant? That is a good question. I believe they do have that answer. I don't know if they're sharing all of it yet, but like I said, according to what we heard from KU executive committee members, like, basically the report that we get, we were told that 95% of the patients are Delta variant. So I believe they're testing it, but I don't know if we specifically are given that results. And then, should I get the flu vaccine the same time as the third Pfizer vaccine? Yeah, again, these recommendations are also coming up about flu vaccination and the relation to getting that. Yeah, I would say, yes, we need to get that vaccination also. And as the flu season is coming up, we do need to get both of them. And whether to get it at the same time or not, again, we'll see more recommendations coming out. CDC will be, coming up with more recommendations on that. Any other questions? Let's see, I hope I answered all the questions. I have some more here on, no, I think we answered all. How do I convince others that I do not need vaccine? I have the COVID, no vaccine, and the infusion. A neurologist said, I do not need vaccine. I want to go on cruise. And they say, no, unless I'm vaccinated. That takes away freedom. Yeah, that is a good question. Yeah, I know you said, I mean, this is not like other viruses. Remember, we all get chickenpox, measles. Again, Rita, that's a good question. I know it takes away the freedom. Sorry, I didn't see your question before, and I think this was in a different Q&A. The others were from the chat, so I was looking at the chat, so that's why I didn't get to these questions. But anyway, so as far as getting vaccination, I understand, vaccination is, whether to get the vaccination or not is, something that your own decision. But based on the evidence and everything, even for smallpox or for chickenpox, people did get those chickenpox and smallpox in the past and got some vaccine, some immunity with that getting the natural infection, but you must realize that we, over the years, all the kids are being vaccinated, and that's kind of what prevents a pandemic, or prevents a global pandemic from occurring from these conditions, because we are vaccinated. And, I understand everyone's immune system is different. Some people have more immunity than others, and it is definitely your choice, your particular choice. Everyone's choices, they own. And the problem is, like, once we get infected, again, unless we are in that situation, we don't realize the seriousness of, how these infections can be. And, again, I mean, from my personal experience, I would say, like, I haven't had COVID, but I had a lot of family members have COVID. And that was because they did not get the opportunity of getting vaccination in India. But, I'm sure it's easier to get vaccination here than other countries. And it has been much more worse. And once they started getting vaccinations, they have been much better. So again, it's a personal choice, I understand, to get vaccination, but we can only recommend that it be be an option that you look at based on how the census is and how it is behaving. And so again, even if you had COVID, like in all my talk, I've mentioned that we know there are antibodies, but the antibodies, we don't know how long they last, how long they give you immunity. We don't know that answer. And if you test the antibodies a few months down the line, they are gone. And for most people, they don't last long. And so we don't know. Again, when you're giving the vaccination, we're trying to also create a memory for the vaccine parts, and that's why we are doing that. And you have to realize, like, again, most of these epidemics and pandemics we are able to control with the vaccination. Again, without vaccinations, I think it would be hard to control all of it. But again, like I said, it's a personal choice, and you have to use your own judgment and see what's good for you. And we can again, I know there are requirements, most of the people are requiring, and especially like you mentioned, I agree, like if you're going to a certain, again, for example, I can say, like, in being in healthcare, if I don't get vaccinated, if I'm a carrier, I might be spreading it to a lot of people. So that's why it's important for me to get vaccinated, so that I don't get the infection, I don't carry it to other people. We still, even if we are vaccinated, we are still being very precautious about, like, because there is a chance I can spread it. That's why, we are still using all the masks, we are using all the, protective equipment, so that we don't want to give it to our, patients. Again, we want to keep everyone safe. And so, and right now, it's not mandated that healthcare workers take the vaccination, but it's slowly being mandated, just like flu vaccination. We are mandated, all healthcare workers are mandated to get the flu vaccination. And even this might be something we might be looking at for, right now, there are a few hospitals are mandating all healthcare workers to get the vaccination to work there. So I think that's something which will be probably be in every place. Again, you have to think about, like, if someone has the infection, they may be off many days, and again, it is also loss of work and loss of having a personnel there, like, to help out. And so there are a lot of things that we look at why it is important to get the vaccination. And any other questions? I think I probably answered all the question. Hopefully, there are many people I know who have had the vaccine, get COVID, harshly weeks to recruit. They will want another vaccine. I think this is another question. Again, there are many people who I know who have vaccine and get COVID harshly weeks to recoup. They will want another vaccine. So, vaccines sometimes can cause symptoms. I understand that. And it's, again, it may be good that they had some reaction to the vaccine, because, one of the things that, I mean, post-vaccination, we did see people have like sore arm, pain in the arm. That's because, when you have pain, I mean, it could be that you have a good immune response to that. Like, I mean, it's basically your immunity might be good, that you're developing a response to that vaccination, in a way that might be the reason. And but you have to realize, like, this usually the symptoms last only maybe a few days and maybe a few weeks, but it doesn't last forever. And the infection, I mean, getting the infection might be much worse. So being in the ICU, if someone is in the ICU, it's much worse. So I would say, like, it's better to have these symptoms for a few days, and it's okay to, I mean, and they do recover from most of those symptoms. But there is a 1% risk that you may have more serious effects from the vaccine, which is same as any other vaccination. So I have to say, I mean, until I came to US, I mean, maybe I wasn't taking vaccination as much as I mean, flu vaccination is not that common in other countries, but that's not available either. So, but we have availability here, and, we have the opportunity, I think, to get that. So I think, again, these are some of the things which you learn from experience, and some of them, you learn from studies and from literature. And so I hope I answered all of you. Do I have vaccination if I had an infusion? I think you asked this question. Do I need vaccination if I had an infusion? Are you talking about infusion with the plasma or the antibodies? I think you had also, I have been told that with the vaccine, my own white cells won't be able to help me with immune compromise issues. The vaccine will take over my own immune system. No, that's not true. That's not true. That's, the vaccine is only for, certain, I mean, they have memory only for this spike antibodies. They're not like giving you for all the other, they don't immune compromise you. It's only for when you're giving the vaccination, you're giving certain antigens, your body is just reacting to those antigens. So the next time when it's like creating a memory, so the next time when there is antibody, like that comes antigen that comes in contact with this, it develops antibodies against that. So I think I probably answered most of your questions there. And I think it's probably time. I see that Dana did say that we are at the time. And if you have any questions, you can always email us and or let Allison know, and we can, we can definitely answer more questions as we go along.
Dr. Pasnoor, thank you so much for all your very valuable information this evening, and for taking your time out of your day to come and educate all of us. We really, really appreciate it. So thank you so much, and thank you everybody for attending.
Yeah, thank you, Allison, for the opportunity, and I hope this was useful. And thank you all for being here this evening.
Thank you.